Hello, good afternoon, my colleagues. My name is Petra Tesarova. I am professor of oncology at Charles University Hospital in Prague. Let me start with oncological point of view of different aspects of onco-nephrology. New cancer data suggests that the global cancer burden and mortality related to the cancer has been on the rise. The International Agency of Research on Cancer estimates that each one of 5 men and each one out of 6 women worldwide will develop cancer over the course of their lifetime, and that 1 in 8 men and 1 in 11 women will die from their disease. Developed countries are facing an overall increase in the absolute number of cancer cases. Worldwide, the incidence of cancer in men is 20% higher than in women. Similar to incidence rates, mortality from cancer is nearly 50% higher in men compared to women. Exclusively among men, lung cancer has highest incidence, followed by prostate and colorectal cancer. After lung cancer, liver and stomach cancer had the next highest mortality rates in men. Among women, breast cancer is the most commonly diagnosed cancer and the leading cause of cancer death, followed by colorectal and lung cancer in incidence, and lung and colorectal cancer in mortality. Cancer is the second leading cause of death and is associated with significant morbidity. Survival rates of patients with cancer have significantly improved over the past few decades. Oncology is no longer the hopeless clinical discipline, the corridor to the cemetery. Many patients, not only with early cancer, but also with metastatic malignancy, live for many years with good quality for a long time, most over them on treatment or with repeated courses of treatment. With the prolonged survival and increasing number of metastatic cancer patients develop kidney disease associated with malignancy or its treatment. A variety of renal complications can occur among cancer patients, including acute kidney injury, chronic kidney disease, proteinuria and nephrotic syndrome, and electrolytic disorders. There are very shortly different problems in onco-nephrology. And this relatively long content of these problems. Professor Jolanta Malyszko from the Medical University of Warsaw will show in her presentation the most important relations between cancer, its treatment, and kidney disease. Thank you.
Good afternoon, ladies and gentlemen. I'm a nephrologist by training. As Petra said, I do work in Warsaw Medical University in the Department of Nephrology. A few years ago, Onco-Nephrology started as a kind of, I cannot say specialty, but a common research and treatment ground between two specializations. And even in NDT, the paper was published about onco-nephrology, a decalogue of problems. So as we can see, the kidney cancer connections is AKI, acute kidney injury, it's chronic kidney disease, cancer, and also electrolyte acid-base disorders. And we do have quite a lot of patients, as we see in our department. Sometimes it's one of third or one half of the admissions are due to oncological or hemato-oncology problems. The kidney cancer connections, they also include problems with nephrotoxicity of anti-cancer drugs, malignancy-related kidney injury, problem with radiation and with RCC and nephrectomy, and also the uremic milieu, which predispose to malignancy. 2 years ago, we tried to summarize the connections between cancer and the kidney. And as you can see from the nephrological perspective, we have the pre-renal problems, intrinsic renal, and post-renal problems. Pre-renal is mainly hemodynamic, like dehydrations, for instance. Renal, it's due to problems with vasculature, with glomerular disorders, interstitial and tubular disorders. Post-renal is mainly due to obstruction in the collecting system. Concerning the connections between cancer-causing AKI or CKD, the pre-renal is the problem with obstruction, vascular compression, decreased cardiac output, hypovolemia, hypotension. It may be also due to the side effects of chemotherapy like diarrhea, emesis, or infectious complications, and also cachexia due to the liver involvement like hypoalbuminemia, edema, and ascites. With the renal part, we may have the glomerular disease, tubular interstitial disease, and also the renal vascular disease. On the post-renal side is generally the obstruction, urinary retention, and also hypercalcemia and hyperuricemia tumorolysis syndrome. Concerning the part of acute kidney injury in association with malignancy, AKI and electrolyte disturbances are the most common features of kidney disease when we do consider the hospitalized patients. And AKI in this particular population is linked with much higher morbidity and mortality. So we can have a direct effect of malignancy, direct effect of chemotherapy, complications of treatment of malignancy, and other factors. The problems directly caused by malignancy due to the obstruction is prostate cancer, urothelial malignancy, ovarian uterine malignancy, and also extrinsic compression from metastasis or lymphadenopathy. Due to the infiltration, we might have problems caused by lymphoma, leukemia, and also the multiple myeloma with cast nephropathy and light chain deposition disease, and also the problems with the complications of hypercalcemia. Direct toxicity from chemotherapy agents, they may cause the glomerular injury or thrombotic microangiopathy, mainly caused by checkpoint inhibitors, VEGF inhibitors, gemcitabine, interstitial nephritis due to the checkpoint inhibitors, or tubular injury due to platinum compounds, methotrexate, trabectedin, or pemetrexate. We may also experience the complications of treatment like pre-renal AKI, like severe diarrhea with irinotecan, nausea and vomiting with other chemotherapy, intrinsic renal injury, sometimes even requiring renal replacement therapy due to the tumorolysis syndrome, or obstruction due to urothelial strictures, like due to the previous surgery, radiation, or even retroperitoneal fibrosis even several years after radiotherapy. Other factors are sepsis, contrast-induced AKI, nephrotoxins like bisphosphonates, non-steroidal anti-inflammatory drugs. During the KDIGO meeting last year in Milan, Professor Walter Stadler, he even told that painkillers are like candy for cancer patients, so that's why we have to be aware of the potential side effects. ACE and ARBs, nephrotoxic antibiotics like aminoglycosides, vancomycin, amphotericin, and also intravenous acyclovir. We also, due to our good collaboration with the hematology, we also can see the AKI post hematopoietic stem cell transplant, which might be due to intravascular volume depletion, systemic vasodilation, renal vasoconstriction, endothelial injury, tubular injury. As we can see that AKI in hospitalized ICU patients is related with much higher mortality, in particular in the stage 3 of AKI, when mortality reached 42%. Concerning another one presented paper from MD Anderson, based on more than 3,500 patients, AKI was diagnosed as 12%, and it was associated with much higher morbidity, 5-fold higher, 2-fold higher length of stay, and also with much higher cost. What we also see that mortality is increased with AKI by rifle criteria, and it depends on the stage of AKI. So survival is much higher with the higher stages of AKI. I do apologize for the Polish translation, but this was the PhD paper from the department, from our department with Dr. Żebrowski, who looked at the causes of AKI requiring renal replacement therapy in the Department of Nephrology. And what he did found that almost 20% of AKI requiring renal replacement therapy were due to the metastatic cancer or hematologic malignancy like leukemia, lymphoma, or multiple myeloma. It was also related to much higher length of stay, and also with in-hospital mortality. For oncology patients, the in-hospital mortality was 65%, when, for instance, with the liver transplant patients, only 44%. Concerning the problem with cancer and renal replacement therapy, we do know that our patients, our dialyzed population, are dying mainly due to cardiovascular disease and infections. However, considering the malignancy, the prevalence is about 6% of incident hemodialyzed patients in US having malignancy as a comorbidity. In some European data, it is close to 10%. So 1 out of 10 of our patients has active malignancy or a history of malignancy. Concerning the CKD and malignancy, we also have completely the same risk factors for CKD as for AKI. From the nephrological perspective, when we do suspect membranous glomerulonephritis, it could be either idiopathic or secondary. For idiopathic, we don't know the real cause, but for secondary membranous glomerulonephritis, we have to rule out malignancy. And the most common is the solid tumors like lung, prostate, breast, and GI cancer. It's like 3B, breast, bowel, and bronchi to be excluded. From the hematologic perspective, if we do have the diagnosis of membranous glomerulonephritis, it may herald the graft versus host disease as well. So in general, in a secondary membranous glomerulonephritis, we do not have anti-PLAR antibodies, which are generally pathognomic for idiopathic membranous. As Petra told that there is an enormous progress in oncology and with the new drugs being registered every year, and we are starting to learn the side effects of these new therapies. We've learned a lot about the commonly used chemotherapeutic drugs. We try to summarize in the paper from NDT the type of drugs and related nephrotoxicity, mechanism of action, and how we can prevent the possible renal side effects. So like for alkylating agents like cyclophosphamide, the prerequisite is adequate hydration using generally acetylcysteine. With mitomycin, which might cause drug-induced thrombotic microangiopathy, which causing direct endothelial injury. So generally, we don't have any preventive measures. We have to think about drug discontinuation and supportive care. For antimetabolites, it's generally adequate hydration. That's the same applies for platinum derivatives. Concerning other drugs, usually we are right now in the learning curve how can prevent, but generally it's only the supportive care. Considering the targeted therapies, there are much more the common caused renal toxicity. And they can cause either hypertension or proteinuria, and also electrolyte disorders and acute kidney injury. What is really important that we don't have any direct proof that if the anti-angiogenic therapy causes hypertension, that it means that they are really efficacious. Sometimes there is not direct relations, but in quite a lot of patients we can see either rise in serum creatinine or proteinuria or hypertension, which might require modification of hypertensive therapy. What is the pathomechanism? Anti-VEGF therapy lower free VEGF and has trophic effects on the podocytes, causing proteinuria. The nitric oxide is decreased, it causing endothelial dysfunction, and it also caused elevation in vascular tone, systemic vasoconstriction, and hypertension. When it goes to the pressure natriuresis, which is lowered, it's responsible for volume overload, which also can contribute to hypertension, which is seen with anti-VEGF therapy. Concerning the kidney part of chemotherapy in cancer-induced kidney injury, in the vascular part, which is due mainly to the hemodynamic problems, the drugs may also cause the TMA. In the glomerular part, we may see TMA or choreoglobulin glomerulonephritis, C3 glomerulonephritis, fibrillary glomerulonephritis, or interstitial injury in the proximal tubules. We may see the light chains, also toxicity due to the drugs. The same applies for interstitium, and also we can have the infiltration in the course of lymphoma or leukemia of the interstitium. In the distal tubules, the typical viscous nephropathy, crystalline nephropathy, and also may due to drugs. And the collecting system, it may we may see the infiltration during the course of lymphoma, leukemia, and also we can see crystals, or we can also have a direct toxic effect of some drugs. So as we can see in the glomerular part, the most toxic could be gemcitabine, mitomycin, and anti-VEGF therapy. In the vascular part, interferon pamidronate. Pamidronate may also cause collapsing FSGS. In the proximal tubules, there is a place for cisplatin, ifosfamide, pemetrexed BRAF inhibitors. In Henle loop is antibodies. In the distal tubules, cetuximab, and in the collecting ducts, methotrexate. So we can see on the very nice screen the same with the histopathological changes like thrombotic microangiopathy caused by mitomycin or gemcitabine or anti-VEGF drugs, FSGS caused by pamidronate, interferon, and also anti-angiogenesis drugs, crystalline nephropathy due to dysproteinemia, drug-induced or metabolic, tubular interstitial injury due to TKI, BRAF inhibitors, immune checkpoint inhibitors, or ATN, acute tubular injury caused by platinums, ifosfamide, pemetrexed, crizotinib, zoledronic acid. Concerning the, I would say the greatest achievements in the recent years are immune checkpoint inhibitors. And also we've learned, first of all, about the side effects, mainly from the autoimmunology. But in the years that have passed, we also learned that they may have kidney immune-related adverse events. And it is due to the fact that when the tumor cells proliferate without surveillance, like tumor-specific T cells, they have cytotoxic effects in tumor tissue, and on the same time, they bind to proteins on the surface of healthy tissues, which are similar to tumor cells. They can cause the production of autoantibodies with no protection against autoaggression, and also pro-inflammatory cytokines generated by T cells have toxic effects. There are several ICI approved by FDA in the recent years, like ipilimumab, nivolumab, pembrolizumab, atezolizumab, avelumab, durvalumab. From the kidney part, generally what we seen on the kidney biopsy, it's acute interstitial nephritis. Usually it goes with proteinuria, and the treatment is generally steroids. We may also see the minimal change disease, but on the other side, if the minimal change disease itself, it's relatively typical glomerulonephritis for young adults or children. If we do see the minimal change disease on the kidney biopsy in elderly patients, we also have to think about the hematological malignancy like Hodgkin or non-Hodgkin lymphoma. Usually they present as acute kidney injury with proteinuria, and treatment is usually steroids. Other kidney problems due to the immune checkpoint inhibitors, it may be IgA nephropathy, focal segmental glomerulosclerosis, or membranous nephropathy. The incidence of acute kidney injury during treatment with immune checkpoint inhibitors, it's not extremely high because it's reached like 5% when combination of ipilimumab and nivolumab. But if we do consider the number of patients, so even the 5% seems that it's relatively high number, and I do think that in our aging population with many comorbidities and many other medications, this percentage might be higher in the near future. The grade 3, it's increase in serum creatinine threefold about baseline, and grade 4 is requirement for renal replacement therapy, which is not extremely common. So the most common toxicity are listed here as acute interstitial nephritis for both CTLA-4 antagonists and PD-1 inhibitors. But considering our particular population, I mean the kidney transplant recipients, there were several reports that in our kidney transplant recipients who developed malignancy and were treated with immune checkpoint inhibitors, the transplant rejections were reported in majority of patients. And sometimes, well, fortunately, the transplanted kidney, even after rejection, the patients can go for renal replacement therapy in the form of hemodialysis, peritoneal dialysis. It's a little bit different for patients with the other organ transplants like liver or heart. So how we can prevent the acute rejection in transplant recipients treated with immune checkpoint inhibitors? So usually it's a steroids in relatively high dose, like 40 milligrams per day. There is a brand new therapy which is called CAR T cell, which is unfortunately not available worldwide. So when tumor presents antigen through major histocompatibility complex to lymphocytes, the tumor may lessen antigen expression, and CD8 lymphocytes may lose their messengers for tumor antigen presentation, and finally, the immune system does not recognize the tumor. So this was the idea to create CAR T cells. So CD8 cells from patients' tumor were cultured and enriched and transfected with CD28, and finally they were given back to patient. So there are some potential targets like CD19, CD22, mesothelin, VEGFR. What we have learned in the recent years that CAR T-cell therapy is extremely effective in young adults with B-cell acute lymphocytic leukemia or diffuse lymphoma. However, this extremely, I would say, sophisticated therapy is also associated with some side effects like cytokine release syndrome, like tumor lysis syndrome, or macrophage activation syndrome. And concerning nephrotoxicity of CAR T cell, the tumor lysis syndrome with AKI, electrolyte disturbances, which may even require renal replacement therapy. Activation syndrome sometimes overlap with multi-organ failure, rising ferritin, and AKI with acute tubular injury as well. Cytokine release syndrome, which is present even in 90% of patients with CAR T cell therapy, and which is also associated with pre-renal acute kidney injury or acute tubular necrosis. How we can manage tumor lysis syndrome, respiratory supportive therapy or renal replacement therapy, macrophage activation syndrome with high-dose steroids, and cytokine release syndrome, we may manage with inhibition of interleukin-6 by either tocilizumab or siltuximab. There is another one issue which is, from our clinical perspective, really important. It's a contrast-induced nephropathy. It's an important drawback of administration of intravascular alienated contrast agents because patients with cancer are treated with a variety of nephrotoxic medications like chemotherapy, targeted drugs, antibiotics, analgesics. They also experience some other problems like anemia, hypercalcemia, hyperuricemia. So they are much more prone to the contrast-induced nephropathy. So we have several clinical scenarios like in most cases there is a mild rise in serum creatinine. In some patients there is a persistent decline in renal functions even with the requirement for renal replacement therapy. And in many patients, the creatinine just returned to the baseline values. However, what I have experienced in my clinical practice that we are asked whether patient can have the CT scan with contrast or without contrast. And the prerequisite is that the patient should have, let's say, normal serum creatinine. If the serum creatinine is usually over 1.5 milligram per deciliter, there is not possible to make CT scan with contrast on the ambulatory basis, and patients need to be hospitalized, at least in my country. What we'd experience with contrast media in oncology patients. What we learned from the literature that patients who are really prone to contrast-induced AKI, so are the patients with other comorbidities like diabetes, hyponatremia, after chemotherapy, during antibiotics, nephrotoxic antibiotics. It's usually it was shown that the crucial time when a CT scan with contrast is done within 45 days from chemotherapy. What is really also important that kidney functions, the baseline kidney functions, it's also risk factors for contrast-induced nephropathy. It was also shown that the chemotherapy and the contrast media are really similar because they may cause vasoconstriction, hyperperfusion, hypovolemia, endothelial dysfunction, and they may have direct toxicity. However, from our perspective, that is a fact that if patients need CT scan with contrast, we should go for a CT scan with contrast, providing the adequate hydration to avoid possible complications, because otherwise when we do CT scan without contrast, we might have not diagnostic image, And then we generally were asked to go for CT scan with contrast. Taking into consideration all the risk factors, the prerequisite is to perform the proper imaging studies for diagnosis, for management, for prognosis, and also to look at all medications and try to avoid or withdraw the possible nephrotoxic medications when we do plan CT scan with contrast. We don't want to delay the diagnosis and treatment. So in summary, malignancy is complicated by AKI and chronic kidney disease from various causes. It can be directly related to malignancy or its therapy. Concerning AKI, concomitant factors such as other nephrotoxins and sepsis can contribute to acute kidney injury. With the tumor lysis syndrome, the prerequisite is to recognize risk factors, to provide intravenous adequate hydration. Use of respiracors is if it's available, and also if there are indications for renal replacement therapy, to provide the therapy as well. For cast nephropathy, high cutoff membranes, high cutoff dialyzers, they have shown some promise, but they are not approved for use, and there are no two studies which were published. They do not show the superiority of these high cutoff membranes. Of course, within some cases or in individualized therapy, they might be useful. Concerning the renal replacement therapy in AKI, in patients with malignancy, usually we do offer. However, sometimes when patients in a critical state and we do have the meeting with the intensivist and oncologist, and if it's the therapy which is considered as persistent, we might withdraw the renal replacement therapy, not to prolong this particular state. Those timing and modality recommendations are similar to patients without malignancy, of course. We also have to consider that if the patients are given drugs, some of them, they are removed by dialysis, so they had to be given after dialysis. And concomitant diseases like diabetes or hypertension, they may contribute to AKI and as well to chronic kidney disease. VEGF inhibitors, they lead to proteinuria and hypertension. They also may cause FSGS, so focal segmental glomerulosclerosis, thrombotic neuroangiopathy, or other podocyte injury. Chemotherapy should not be interrupted for most patients with proteinuria and hypertension. We might consider the modification or adjustment of hypertensive therapy. Membranous glomerulonephritis is associated with malignancy, and patients with membranous glomerulonephritis with negative PLAR testing should be screened for malignancy with 3B on the top, breast, bowel, and bronchi. Concerning the ESA use, they should be used cautiously in patients with a history of malignancy and avoided, if possible, in those with malignancy. In general, what I have found that the blood pressure goal during VEGF inhibitors therapy should be below 130/80, and cautions should be exercised with RAS blockers if patients has recurred episodes of volume depletion. Coming to the end, I would like to quote Murphy's law of specialties, and the quality of provided healthcare is inversely related to the number of participating specialists. But we do think that the close collaboration between oncologists, nephrologists, palliative care specialists, intensivists is really of value to yield the best possible outcomes for our patients. Thank you very much.
Thank you, Jolanta. It was a really wonderful presentation, and thank you for time, because we have space for some questions. And I have a first question related to erythropoietin indication. You mentioned new rules for this application. It's very important question, because a number of patients with active malignancy in renal replacement therapy is increasing, and erythropoietin for treatment and support in chronic kidney disease with anemia is very important. And for patient with active malignancy or patient with malignancy in history is relatively danger only in over-treatment with erythropoietin stimulating agents. And then is very important to see hemoglobin level, because if this hemoglobin over 100, then it's necessary to stop treatment with erythropoietin in this subset of patients in dialysis. We know that patients with malignancy, mostly with radiotherapy and without chemotherapy, is stimulating by erythropoietin with progression of cancer, and this is main reason for very careful approach to this indication.
Absolutely, Petra, because, well, erythropoietin is a cytokine, is a growth factor. So that's why we have to be aware. We've also learned from nephrology world, from the TREAT trial, that aiming to high hemoglobin is not very good. And also there was some safety hint that in patients with malignancy, we should be really very careful with erythropoietin stimulating agents.
Of course, but it's not necessary completely avoid this treatment, because it's very unpleasant for patient on dialysis be with deep anemia, but it's necessary tailored this approach in individual patient.
Absolutely right.
I don't know if you have any other questions about this very comprehensive and complicated topic.
Dr. Tesarova, the questions are coming up in the questions tab.
I have here only one question, and this is answered.
You don't see the others?
No.
Have you tried to making the box bigger? You must click on the icon that is it's a square with an arrow on the right of the questions.
I have problem with see it. I have here only one question and one answer.
Okay, I can read the questions.
Mm-hmm.
Yeah.
Perfect.
Okay, so the next one is a question by Al-Shima El-Tahan, and should we stop chemotherapeutic agent in case of complications?
Yeah, thank you. It's very important question, maybe for multidisciplinary oncological team with presence of nephrologists as well. because it's relatively individual in different type of treatment. But for patients with elevation of creatinine and decreasing of kidney function, is necessary to stop treatment, or is possible in some cases modified application of the treatment, and in some cases we could start treatment with different type of chemotherapy or targeted treatment after resolving of this problem.
And I think this is also the problem, because like in my country there is some called therapeutic programs. So like for cetuximab, for instance, the oncologists are not allowed to give the drug when creatinine is over 2. So if creatinine goes over 2, they cannot continue the therapy. The funny thing is that when patients do dialysis, he or she is eligible for this therapy, despite the creatinine is really high. But on dialysis, on renal replacement therapy, the therapeutic program allows to treat. So I think it's country specific.
I think problem is timing of the treatment in dialysis program, because we have a lot of drugs who are clearing by dialysis, and it's necessary to indicate good timing for
Yes.
application according to effectivity of this treatment.
Absolutely.
Okay.
And it's generally applied to chemotherapy, because the targeted therapy is around quite large proteins and they're not cleared by renal replacement therapy. So that's much easier, I guess, for oncologists.
Yeah, of course, and it's very reasonable to start with some information from both parts, from oncological and nephrological point of view, before starting of this treatment.
Sure.
All right. Next question. It's very long, so I'm going to do my best. The mentioned relevant renal replacement therapies with its associated mortality risks, is it any specific RRT like hemodialysis or peritoneal dialysis, or just any kind of replacement therapy?
I don't understand exactly.
So I think the person is asking if the renal replacement therapies suggested are specific like hemodialysis or peritoneal dialysis, or any.
So if may I answer the question, if we are talking about acute kidney injury, we might have two choices between generally intermittent hemodialysis and continuous renal replacement therapy, CRT. Sometimes we can do hybrid techniques like SLED, slow, low efficient dialysis. With AKI, if it's only the problem general with AKI, and if a patient is transferred to a nephrology ward, usually intermittent hemodialysis is used. In a case that if AKI is complicated by other organs failure, usually the patient is in ICU. And in ICU or in the intensivists, generally they do prefer CRT instead of intermittent hemodialysis. Concerning these two modalities as well, if the patient is hemodynamically unstable, CRT is also preferred in comparison with the intermittent hemodialysis. But as far as I remember from one of the ASNs, the Professor Malyszko told that the choice between CRT and intermittent hemodialysis depends upon, of course, the clinical state, but also depends upon the availability of the treatment and experience of the department. Because, well, there is no hard data to prove that one treatment, I mean intermittent hemodialysis or versus CRT, is superior. So it's generally individual. Concerning the end-stage kidney failure, when patient approach with patients with a CKD have deterioration of kidney function, so usually we do offer intermittent hemodialysis. With peritoneal dialysis, in general, all over the world, this is not leading modality of renal replacement therapy. It's offered to a small percentage of patients, and usually we do not consider it as a first modality. It depends upon the center, but with AKI, it's choice between CRT and intermittent hemodialysis. For end-stage kidney failure, it's generally hemodialysis. And we have, of course, to be aware of drug clearance. If the drugs are cleared by renal replacement therapy with intermittent hemodialysis, it's much easier for us to think about the dose adjustment. For CRT, the data are really, really scarce.
Okay. Another question that is from the same person is there any studies that associate the oncological mortality risk in patients with renal transplants irrespective to the immunosuppressants used?
If I may answer the question, it was a big discussion during the KDIGO meeting in Milan last year. If the patient has a history of malignancy, so first of all, we do have the certain rules when the patients could be or should be evaluated as a potential kidney transplant recipient. In general, if there is only the history of malignancy, there is a standard immunosuppression because there are no hard data that mTOR inhibitors as a part of immunosuppressive therapy, they are superior to the standard immunosuppression. If there is a problem with malignancy after kidney transplantation, so the first approach is to minimize immunosuppressive therapy, and it has been shown that mTOR inhibitors like sirolimus or everolimus, they lower the incidence of skin cancer, but it was not shown for other type of cancers.
Okay, we have many questions coming in, so I'm going to go fast. During renal transplantation, immunosuppressants given, but if any infection is caused, antibiotics are given. Will antibiotics do not interfere with the functioning of newly kidney grafted as it is sensitive to workload?
During kidney transplantation, there is, I would say, the local policy to give antibiotics, and in some centers, it's usually to give antibiotics which are not nephrotoxic. We try to avoid as much as possible. And also concerning the immunosuppressive therapy, we try to avoid the macrolides and tetracyclines because they do interfere with the levels of calcineurin inhibitors. So generally, it's beta-lactams or penicillins, cephalosporins.
Next question is, are you aware of any new data on HIF stabilizer safety issues related to cancer patients?
To my knowledge, what I have learned from either publications or from congresses of KDIGO-ISN, there were no safety signals, but still we do not have long-term data concerning HIF stabilizers, as we don't know that they do affect VEGF system. So it was a real concern, but we still have to wait for long-term data. So far, there were no safety signals.
Okay, other question, and Petra, please feel free to comment and chime in when you feel necessary. It's always interesting to get two different opinions. Next question is how you propose to treat patients with known AIN secondary to CPI that need to restart the CPI for tumor progression. Hello?
Sorry, I have problem with hearing.
Yeah, I will.
I don't hear this this question.
I will read it again. Can you hear me?
Yeah.
Okay. How do you propose to treat patients with no AIN secondary to CPI that need to restart the CPI for tumor progression?
It's a relatively complicated question because it's individual, because we have patients with different stages of cancer, and if we have patients with early stage of cancer, it's possible to treat this patient and then evaluated this approach. But for patients with metastatic stage of cancer, it's necessary to avoid this treatment.
Okay. Another question is, have some data about association of antioxidant and anti-neoplastic drugs to prevent kidney injury? There are several studies showing good results in animal studies.
I think this approach is not in this time in clinical practice, but trials are really very interesting, and outcome are for our patient hopeful, and we have not so problems with patient treated with treatment, classical nephrotoxic treatment, for example, platinum chemotherapy, because this therapy is connected with a lot of preventive hydration regimens, and these patients are very strongly followed. But we have problem with treating of new drugs and drugs with nephrotoxicity, which is relatively rare. And in these cases, we have problem with developing of acute kidney injury or maybe in chronic kidney disease.
Next question is, how should we approach patients with peritonitis carcinomatosis with ascites and high serum creatinine, but without RRT indication?
It depends on type of the tumor, because we have patients with, for example, breast cancer with peritoneal generalization and ascites, and this is limitation mostly in liver function than in renal function, and we have, for example, patient with ovarian cancer. In this type of the tumor is peritoneal cancer disease very often, and in this time we could use relatively broad spectrum of antineoplastic therapy.
Next question is, do you stop VEGF therapy if the patient is suspected to have thrombotic microangiopathy?
Microangiopathy is unfortunately in most cases a sign of poor prognosis of our patient, and in this time we stop anti-cancer treatment and treat it with low molecular weight heparin, and observe these patients because HUS is relatively danger complication, and it's a sign of poor prognosis and terminal stage of cancer.
Okay, and here is the last question. Is there any role for plasmapheresis in VEGF-associated TMA?
I don't have any opportunity to use it, and I have no patient with this treatment, but I know that we have some literature information and outcome of clinical trials, and it's possible, but in our department it's this treatment approach not so often.
Jolanta, how about you?
Generally, for plasmapheresis, there are no hard data. From other indications we're doing from time to time, but there is no literature behind. Usually there are historical data. What we are doing in our department, we do provide plasmapheresis for the whole hospital, but for autoimmunology diseases, for neurological diseases, for rapidly progressive glomerulonephritis, but not for this indication.
Okay. These are all the questions that have come in until now. I don't know if Jolanta, you wanted to add anything, or Petra, you had any questions for Jolanta or anything to add?
First of all, I would like to thank you, ASN and the KDIGO, to consider this particular topic. First of all, for Milan conference and also for this webinar, because from my nephrology perspective, we are dealing with more and more patients with malignancy and also with adverse events after oncological treatment. So for us, it's like a really very challenging issue, and I do think that we have to learn much more.
I think as well, because cooperation between oncologists and nephrologists is very important for destiny of our patients. Thank you so much.
Thanks to both of you for taking the time and teaching us this very important topic. I'm sure the audience enjoyed the webinar as much as I did, and the webinar recording will be published on the ISN Academy during the course of next week. So if you have colleagues who have missed the webinar and want to see it, they will be able to do it on the ISN Academy. Okay, so thank you to Jolanta Malyszko and Petra Tesarova, and thank you to the audience for their time. Bye-bye.
Thank you so much. Have a nice weekend.
Nice weekend. Bye-bye.
Thank you.